Good evening to one and all. Welcome to yet another session of our Young India Intensive Age Sunday webinars. Topic for today is a very important one, weaning. Well, weaning is an art and a clinical judgment aided by all the scientific principles. So we have for us today Dr. Chandrashish Chakravarty sir. Sir is a senior consultant at Gleneagles Hospital Apollo, and he'll be taking us through this process of weaning right up till the latest trials. A very recent trial was published in NEJM, and he'll be talking about that too. So over to you, Chandrashish sir. Audio, Chandrashish, audio is gone. Just click on the audio.
Thank you, Dr. Tapesh, for a lovely introduction. Weaning is a little bit of a complex topic, and I think it's difficult to touch all parts, but I'll try to make it present. I'll try to present it in such a way which is helpful for the students, because I think that's the primary purpose, so that people who are going to sit for exams, they can get an idea about how to answer questions and the basic things about weaning. Is my screen visible?
Yes.
Yes. Okay. So I've tried to divide this topic into 10 commandments. That is the major 10 things, in a nutshell. In a practical ICU scenario, we need to keep in mind as far as weaning patients from ventilation is concerned. So the first is how to identify patients who are ready to get weaned off. Now, the first thing that should be taken care of is whether the patient is ready to get weaned, that is readiness to wean criteria. I'll talk about it in the next slide. And once you decide that this is a patient who is ready to be weaned, the most popular ways of weaning a patient is either to give them a TP's trial or take them off the ventilation completely and put them on a TP's, or to keep them on and do something that's called a low pressure support ventilation trial. When we say low pressure support, we usually mean a pressure support of 4 to 8, usually not more than that, unless you have been forced to place a very small sized endotracheal tube for some reason. Now, how long should this trial or a spontaneous breathing trial be given? Our studies, very large studies published, although long back, by Esteban from Spain. And he clearly showed that you can give them a TP's or low pressure support ventilation trial from 30 minutes to 2 hours. And there is no difference in the success of weaning, whether you give them a trial of 30 minutes and then do a blood gas, or you give them a trial of 2 hours and then do a blood gas. So 30 minutes is good enough. But it's preferable that not to keep somebody on a low pressure support or TP's for more than 2 hours before you decide to take them off from the ventilator, because by that time the patient may get very tired. Now, the next way of weaning is called a protocol-based weaning. Now, please, we need to remember that most patients are actually kind of liberated from the ventilator and not really weaned off. When we mean weaned, the word weaning comes from just like wean babies from breast milk to solid food. It's a slow, gradual process of taking them off from mechanical ventilation. But in majority of the cases, I would say 75% of patients, we don't really wean them. We come and we decide that there's a patient who is ready to get liberated from the ventilator. We just take them off from the ventilator on a TP's or put them on a very low pressure support. and assess that how they are breathing, and then we take them off from the ventilator. So it's kind of a liberation. But there are ways of protocol-based weaning where usually done by respiratory therapists where they are available in the world. We don't have them in most of the Indian hospitals, but nowadays in some of the hospitals they are coming to work. So they every morning they are supposed to look for readiness to wean. They have a checklist and they go through the checklist and decide that this patient is uh, weanable or ready to be weaned off. Then during the rounds they discuss, and if the consultant is happy to take them off from the ventilation, then they go through that protocol based weaning and then they take the off from the ventilator. And in a small percentage of cases, you have to actually keep on reducing the support. Usually pressure support is the most popular mode of weaning, and you slowly reduce pressure support and then take them off from the ventilator, although that's not very popular. So how do you assess readiness to wean? The first thing that is said in all textbooks is to make sure that the disease is either largely taken care of, or it has improved significantly to a point that this patient does not need mechanical ventilation for whatever reason it was started. Now, it is a concept which is really not very well defined, that when do we say that the disease has resolved? To what extent it should resolve? Like if somebody has a pneumonia, do we really need for the whole process of pneumonia to get better, or should it just get better good enough that they can be taken off the ventilator? If somebody was intubated for unconsciousness, then it is probably a slightly better defined that the consciousness has improved. So this is not a very well defined entity, and it largely depends upon the physician gestalt or the physician's decision, the consultant's decision to decide that when the disease has large or has improved to a significant extent, that the patient can be weaned off. Next, let's talk about the airway and breathing. It is imperative to make sure that the oxygenation and gas exchange has improved before we decide to take somebody off from the ventilator. One of the objective ways of measuring it is to do a blood gas and see that the partial pressure of oxygen is more than 60 millimeters of mercury and the FiO2 is less than equal to 40%. Now, some people are slightly more liberal and they will accept an FiO2 of 50% because the whole philosophy is to take patients off from the ventilation as soon as possible. But the more liberal you keep the criteria, the higher the chances of weaning failure or post-extubation respiratory failure. Second is how much PEEP this patient is on. Almost all people will agree that PEEP should be less than 10, and most of the studies or most of the guidelines will suggest that the PEEP should be equal to or less than 8 before you take them off from the. Chest X-ray should be either stable or they should be improving. Again, this is not very well defined, but again, depends upon physicians gestalt. What about circulation? Now, the obvious targets of circulation in an ICU remains the same. That we try to keep a mean blood pressure of more than 65, blah, blah, blah. But what about on vasopressors or inopressors? So this is a study which was published in the Blue Journal, studied from Canada, Calgary, by Zarabia et al. And they found that if you are on vasopressors, but on a dose of norepinephrine or other vasopressors, which uses similar calculations, if your vasopressor dose is less than equal to 0.1 mics per kg per minute, then you can be weaned off, and there is no increased failure to weaning when compared to patients who are not on vasopressors. So you need not be completely weaned off vasopressors before you start weaning or you take them off the ventilation. However, if the vasopressor dose is high, more than 0.1 mics per kg, then the chance of failure to wean is higher, and there is more and also higher mortality in these patients. We also need to make sure that there is no active ischemia, myocardial ischemia, or active arrhythmias which are happening while the patient is getting weaned off. Sometimes we find that when you start the patient, when you put the patient on a weaning mode, then they kind of develop an arrhythmia, or they have significant ST changes, and these are also indications that they are not going to tolerate the weaning. We need to remember that weaning is a big stress for the heart, and if you look at the heart-lung interactions, that once we start taking somebody off from positive pressure ventilation, slowly reduce their positive pressure ventilation, the heart-lung interaction is such that in a weak heart, the preload will increase, the afterload will increase, and that's going to make the heart more prone to failing, and the myocardial oxygen demand will go up, so that will increase the chances of arrhythmia and ischemia. We'll talk about weaning in cardiac patients in a little while. Now, lastly, D, or the sensorium. Again, we all know that one of the accepted indications of invasive ventilation or putting an endotracheal tube when your Glasgow coma score is low or less than 9, some people say less than 8. But if your GCS is above 8, is that the level at which you take them off from the ventilation? Or do you wait till they start following commands? And what do you do if they will never follow commands, like neurological patients, certain neurological patients? So this is not very well studied, but most of the time we tend to believe that the patient should be at least be localizing pain, that is M5, and preferably the patient should be opening eyes to voice or command, and if they are following commands, then that is the best for somebody to take them off from the ventilator. You can take patients off from ventilation even if they are not following commands, but then they will have a higher chance of post-extubation failure, or they might require a more permanent airway like a tracheostomy. It is also very important to rule out that the patient does not have an hyperactive delirium. Hypoactive delirium is okay, acceptable, but hyperactive delirium is something that will prevent weaning. Severe neuromuscular weakness obviously is something that is going to prevent weaning. What I usually use is I ask the patients to raise both their arms above their head if they're following commands, and I assess for neck holding, if they can hold the neck when you remove the pillow from the bed in a patient who is propped up in bed. So if somebody has a good neck holding and can raise both arms above the head, usually they can be weaned off from the ventilator. Now, LI suggested a mnemonic which is called wean snot. This I thought will be interesting and useful for students. So these are the modifiable factors that can hinder progress towards extubation. And when you are considering somebody for extubation, we need to make sure that we have been able to control these things as far as possible. The wheeze has significantly decreased in a COPD or asthma patient from the point they got into a ventilator, if at all. the heart disease has been taken care of, the offloading of fluid has happened, the electrolytes have been corrected, there are no major metabolic derangements. Delirium, I've already talked about, is taken care of. Neuromuscular disease and weakness should have improved. The sepsis should be under control, or there should not be an indication of a new brewing sepsis or nosocomial sepsis. Nutritional insufficiencies can cause weaning failure, particularly if somebody is completely off nutrition for a long time, particularly surgical patients. Opioids and other sedatives, we should be very sure that we have stopped the sedation for significant duration of time. Please remember that sometimes we tend to use sedatives which apparently has got a short duration of action, like let's say benzodiazepines like midazolam or opioids like fentanyl. But when you have given them to patients for a long time over as an infusion, then their half-life increases significantly, what we call a context-sensitive half-life. And this context-sensitive half-life can be almost equal to long-acting drugs like morphine or lorazepam, etc. So it's very important that you have stopped these drugs if you're using them for sedation quite before you have decided to take them off from the ventilator. And also metabolic endocrine diseases, if you feel that a patient is failing weaning, then we usually check for thyroid disorders. Among the electrolytes, I must mention that we often check sodium, potassium, but we forget to check phosphates. I have seen quite a few patients who have gone into severe respiratory failures and weaning difficulties because of very low phosphates. And where do we see such patients? Number one, we see such patients in young patients who come with diabetic ketoacidosis. You have been correcting the hyperglycemia and the hypokalemia with potassium, but you have forgot about the phosphate and never checked it. And their phosphate drops below 1, they become 0.8, 0.7, and they go into bad respiratory failure. And even if you're trying to wean, they go into weaning failure. So remember about phosphate when you are weaning patients. Please check them, particularly in patients where you have the risk of hypophosphatemia. Now, the second commandment is, what are the weaning indices? Now, there are various weaning indices, and this is often asked in the examination. Some are objective, some are subjective, and some are called integrated indices. I'll first talk about the subjective indices. Subjective indices means when you start somebody on a weaning mode, you will find that you need to obviously monitor the vitals. So if somebody's blood pressure, heart rate is fluctuating beyond 25 to 30% from their baseline, then that's an indication that they are not going to tolerate the weaning. So if somebody becomes very hypertensive, very tachycardic, or opposite, hypotensive, bradycardic, they're not going to tolerate weaning. If you find a lot of accessory muscles are working, the patient is visibly getting increased work of breathing, tachypnic, increased secretions in the tube, and these are all subjective indications which should be picked up by the bedside nurse or the bedside technician or the bedside physician to decide that this weaning trial is not going to succeed. What are some of the objective measures that you can see before you start weaning somebody? So if somebody is requiring a minute ventilation of more than 10, or some books say more than 15 liters per minute to maintain their carbon dioxide levels, then that is too much of a high minute ventilation to take them off from the ventilator at this point. If you are very tachypnic, your respiratory rate is more than 30, or your FI requirement is 50%, then again, these are objective weaning, objective criteria which should prevent you from starting to wean. If you are not sure that whether this patient has got enough breathing drive, for example, patients who has got neurological, particularly related to the CNS, central nervous system problems, you can check the central drive by doing a P.1 test. And some patients may not generate good inspiratory pressures. So you can check the maximum inspiratory pressures, MIP, by these are things which can be done in certain ventilators. You have knobs, you have options, just press it and the ventilator occludes the valves and gives you a number. But again, remember, these are very variable. The numbers will change. So always take multiple set of readings and then take an average. We don't decide from just one reading. And there are some integrated indices like the crop index, core index, etc. I'm not a great fan of these indices. You can find it in the books. They basically include various things like what is the oxygenation, what is the respiratory rate, etc., minute ventilation. Put it all together, give you a number, and then if the number is higher than that, you say that okay, this patient is ready to get weaned off. Now, most of the studies have actually, or most of the discussions about weaning nowadays are coming to a conclusion that these kind of integrated indices, number one, are impractical at the bedside unless you have somebody who has got a list in their hand and trying to check it. Secondly, these are unnecessary and somewhat delays weaning. So these are again going out of favor. Now, one of the weaning indices that has stood the test of time and has been largely talked about is called RSBT, or Rapid Shallow Breathing Index. Now, what is a Rapid Shallow Breathing Index? This was first described by Young and Tobin. Young and Tobin basically measured or attached a handheld spirometer to the endotracheal tube 1 minute into a TP's trial after disconnecting them from the ventilator. And they measured what is the tidal volume in this handheld spirometer, and also they calculated what is the respiratory rate of this patient. And they divided the respiratory rate by the tidal volume generated. The tidal volume, remember, here will be in liters, not in milliliters, but in liters. And if the number is less than 105, that's of a weaning success. Now, the problem is nowadays, number one, when we give them a TP's trial, we don't have a spirometer to measure how much tidal volume they're generating. So this F by PT, if you want to do it on a TP's like the original study, you'll need a spirometer to find out how much tidal volume. And in most of the TP's trials, when this study was reproduced in various other centers, the general accepted F by VT is 100. So if it is more than 100, then the chance of weaning failure is high. However, there are people who studied RSBT on CPAP while the patient is connected to the ventilator, or a low pressure support while the patient is connected to the ventilator, because when the patient is connected to the ventilator, you can measure the tidal volume generated and you can measure the respiratory rate. So here they found that this number 100 obviously becomes much less, because the ventilator pressure support is a support to the patient's breathing effort, and CPAP itself is a support to the patient's breathing effort. So these numbers from 100 changes to 46 with pressure support, or 63 with CPAP. So if you want to use RSBT in a modern context, keeping the patient on the ventilator just on a CPAP of 5 or a pressure support of 5 and a PEEP of 5, you can use these numbers 46 and 63 as a cutoff. The third is, what is the best mode to wean? Now, people have debated on this for a long time. The first one of the major on this was done by Esteban, and again, it was in 1900s, as far as I remember, and probably published in NEJM, but I may be wrong. He looked at 3 weaning modes. One is SIMV, the other is pressure support, and the third is TPs. So the mean duration of ventilation in the SIMV group he found was 5 days versus 4 days for pressure support and 3 days for TPs groups. In the TPs, actually, he had 2 groups. One in which he just gave 1 TPs trial per day, and in another, he used to give multiple TPs trials every day. So what came out from this study by Esteban is that SIMV is one of the least efficient modes of weaning. Pressure support is the next best, but the best is probably just to give them a TP's trial every morning when you go for rounds, and if you find that the patient is ready to get weaned off. However, when they compared between pressure support, low pressure support, and TP's group, they found that the weaning trials actually failed more often in the TP's group than the pressure support group, which was around 22% versus 14%, and which makes sense because there are certain group of patients who are definitely going to fail a TP's trial, but might get weaned by a low pressure support, and then if you can put them on a ventilator. Sorry. Now, before you give a trial of extubation, what are the things you need to consider? So now that you have seen that the patient is ready to get weaned off, you have done the weaning trial, and your blood gas and everything is fine on either the TPs or what we call a spontaneous breathing trial or a low pressure support trial. So before you take somebody from the ventilator, what are the things that you need to consider? Number one, the time of the day and the junior staff at night. So this is very important for the consultant to know that, are you going to extubate somebody at 6 p.m. or 8 p.m. at night? And if you do, then do you have a person to take care of the airway or reintubate this patient if required at night in the ICU? Or somebody who can take good decisions. So what is your junior staff at night? How are you staffed? How is your nursing staffed? And preferably most of the weaning and most of the extubation should happen during the active hospital hours. When we say active hospital hours, we probably mean 8 a.m. to 8 p.m., something like that. Second is does this patient have a difficult airway? So if this patient has a difficult airway, then you should not extubate this patient, or you should not ask to extubate this patient when expert help is not at the bedside. So you should be prepared with all the airway equipments, etc., because if you have to reintubate, you need an expert hand. Does this patient again need the ventilator very soon, like say within 12 or 24 hours? For example, this patient is again going back to the OR for a general anesthesia. Then you can probably talk to the surgical team and decide that this patient can be on a ventilator for one more day, and then take him off after the GA. Does this patient have a high risk for laryngeal edema? I'll talk about that. And if yes, you can go for a cuff leak test to decide that. Also, in all patients, please make sure that the patient has a good cuff reflex, the airway secretions are low, and the patient has a good mentation once the sedation is stopped. How to do a cuff leak test, or what is a test? Now, before you extubate, keep the patient on a assist control, volume control mode, and suction the endotracheal tube well. Record the inspirated tidal volume before deflation of the cuff, and the expirated tidal volume after 6 cycles of cuff deflation. Now, if the difference between these two tidal volumes is less than 12 to 25% of tidal volume that you have been given, or is less than 110 ml, then the cuff leak test has failed. Now, if the cuff leak test fails, it does not mean that the patient will not tolerate extubation. In fact, most people will not even do a cuff leak test. However, if the cuff leak test is positive, if the difference is high, that means is more than 110 ml or more than 12% of the time, then the chance that this patient will go into a post-extubation stridor is very, very less. So this has got a negative predictive value of 98% for post-extubation stridor, and the original study was done by Miller and Cole. And however, it does not mean that if the cuff leak test has failed, then this patient will not pass the extubation trial. So this has got a negative predictive value. So what are the risks of post-extubation stridor that you should consider before extubating somebody? The risk factors are: number one, female patients who has got a short neck, if somebody has an airway or laryngeal stenosis to begin with, trauma to the airway, multiple intubation attempts, prolonged intubations for more than 36 hours, patient has remained agitated or delirious on the ventilator, which basically means that there was a lot of tug on the endotracheal tube and the cuff because the patient was moving here and there with the tube in his or her mouth. If there has been a lot of airway manipulations, and if the endotracheal tube was stuck while you was trying to pull it out. Most of the treatment that has been discussed or studied are pre-treatment. So once this has happened, it's kind of a little difficult. But if you are suspecting somebody to develop laryngeal edema or post-extubation stridor, you should pre-treat them with IV steroids, dexamethasone 0.15 milligram per kg, or methylprednisolone 20 milligrams to 40 milligrams. There have been multiple trials, and there has also been meta-analysis on this. And this, whatever you are giving, whichever steroid you are giving, either dexamethasone or methylprednisolone, either you can repeat it every 4 to 6 hours for 24 hours or 12 hours. Last dose must be given at least 4 hours before the extubation. If you are not giving it at least 4 hours before extubation, then probably it's not going to make much of a difference. And also, it is not necessary to give steroids to all patients, but it's only useful in high-risk patients for extubation, post-extubation stridor. If it has already happened, give them high-flow oxygen and nebulize them with adrenaline, ideally racemic adrenaline. Unfortunately, it's not available in most of the centers, at least not in my centers. So you just use a 1:1000 dilution of adrenaline and use a 5 ml to nebulize them. Be careful about any arrhythmias which might happen if you are nebulizing with adrenaline. What to do on extubation failure? Well, do you put them on a non-invasive ventilator or you reintubate them? This is a question that has been well studied, and most of the trials have said that non-invasive ventilation is not a good option after post-extubation respiratory failure, except in few situations. And I'm going to talk about it, as Dr. Bansal mentioned, that there has been few studies recently on weaning, and one of them is this. I'm going to talk about it. And the second is reintubation, probably better if the patient has failed extubation. In the meantime, you can use high flow nasal oxygen, and you can try to reverse things which are causing extubation failure, maybe a wheeze, maybe a post-extubation stridor, etc. And if it fails, if you have given HFNO trial for maybe in 1 hour or so, or 2 hours, and if you that the patient is worsening, you probably reintubate them and don't put them on an NIV. In a good ICU, the reintubation rates are usually 10 to 15%. If your ICU has a reintubation rate of 0%, that means you're actually not trying to wean them early. If the reintubation rate is too high, then probably it means that you are weaning them without considering other factors. And remember that once the patient has failed extubation and has been reintubated, that predicts a higher mortality. The fifth commandment is automated weaning. Is there any role of automated weaning? So nowadays there are certain closed loop ventilations which have come up. The most well studied of this is called ASV, or adaptive support ventilation. Adaptive support ventilation combines a pressure regulated volume control and a volume support ventilation. And the clinician has to actually set the minute ventilation or percentage of minute ventilation that he wants the ventilator to provide. Okay, so for example, if for the patient's height and weight, the predicted minute ventilation is X, then the physician has to decide that maybe I want the ventilator to provide 130% more minute ventilation than is usually required at rest, or 200% more minute ventilation, etc. And then as you come down on the target, the ASV automatically starts weaning to a volume support mode. There is little evidence to say that ASV is better than the traditional weaning modes like pressure support or just spontaneous breathing trials. It probably has a role in weaning patients in ICUs which are not very regularly staffed with intensive care physicians, like cardiothoracic ICUs, or ICUs which are in peripheral small hospitals, mostly run by nurses and maybe controlled by intensive care physicians over telemedicine. So these ICUs will probably benefit from such modes. There has been other studies of proportional assist ventilation with pressure support, which has shown that proportional assist ventilation has shown a little earlier weaning than pressure support ventilation. However, it has not become very popular because, like pressure support, it is not available in all ventilator uh, companies or models that is usually used. And in specific situations, higher or more difficult ventilation modes like NAVA may be useful to wean patients, particularly those in which they are having a lot of asynchrony with pressure support or a lot of asynchrony during weaning, or there are problems with neurological problems which may be causing delayed or difficult weaning. Now, role of non-invasive ventilation in weaning. So the role of non-invasive ventilation comes in difficult weaning patients, and particularly in three categories. One is in obese patients. So in obese patients, there is good evidence that you can wean them off from an invasive mode to a non-invasive mode. And then the reason is because these patients, because of the physiology, they have a higher positive pleural pressure, they have a higher tendency to develop basal atelectasis, and non-invasive ventilation, particularly CPAP or a higher EPAP, is going to prevent that. So in obese patients, there is good evidence that NIV, planned NIV or transition from an invasive ventilation to a non-invasive is going to be helpful. Second is cardiac patients at risk of heart failure. So these are patients, as I was mentioning, mostly fail a TP's trial. It is preferable that these patients are basically weaned off from a low pressure support trial and put on an NIV mode, and then slowly weaned off the NIV. The same is true for COPD. In fact, nowadays we are saying that the ventilation of COPD can be divided between invasive and non-invasive mode. As soon as possible, you get a window, you take them off from the invasive mode and put them on an NIV mode, because NIV is the preferred ventilator, preferred form of ventilation for most of the COPD exacerbations and COPD patients. And you can actually transition them from an invasive to NIV mode as soon as possible. So NIV-based weaning has got evidence and should be done for obese patients, patients who are prone to heart failure, and COPD exacerbations. Now, this is one of the studies called the BREATHE trial, BREATHE randomized control trial, published in JAMA, effect of protocolized weaning with early extubation to non-invasive ventilation versus invasive weaning on time to liberation from mechanical ventilation among patients with respiratory failure. This trial, unfortunately, did not show any benefit of protocolized weaning with early extubation to NIV versus the traditional weaning, invasive weaning. There are certain criticisms of this trial. The first is, this is a trial which has only happened in UK. This is a trial which is, although it was done for almost years, but the number of patients were less than 200, something 180 or something. And most of the patients were actually either pneumonia patients or post-surgical patients. They were not patients who actually benefit from NIV-based weaning like COPD or heart failure. There were COPD patients, but very few, I think less than 8 or 10 patients. So I will still probably in my practice continue to wean them to NIV if I think that they are going to physiologically benefit from NIV, like, as I mentioned, obese, COPD, and heart failure patients. What about cardiac dysfunction? So cardiac dysfunction is one of the major causes of weaning failure. So you start somebody to wean and then they go into a pulmonary edema and fail weaning, and you put him back on full volume control or whatever control mode. Now, how do you understand, or how do you realize that cardiac dysfunction is causing weaning failure? It is easy if you know that the heart is not pumping very well. For example, patients who have got a poor ejection fraction, or who has got a heart failure with reduced ejection fraction to begin with. However, there is a growing subset of patients who are having heart failure with preserved ejection fraction, also called HFpEFs. And these patients are the most difficult to realize that why they are failing to wean from the ventilator. So there has been quite a few methods described in literature. One is to measure brain natriuretic peptide levels just before weaning trial and half an hour to 1 hour into the weaning trial. And if you see that the BNP levels have significantly gone up, then that is an indication that this patient is cardiac failure is actually causing the weaning failure. Similarly, you can look at the EA ratio. Lamia studied this and found that a combination of EA ratio more than 0.95 and EA ratio of more than 8.5 measured with a transthoracic echo at the end of a spontaneous breathing trial is one of the indicators of a weaning-induced pulmonary artery occlusion pressure elevation. Again, you have to, I'm not very sure about the practicability of these things, because these are advanced echo parameters, which when the patient is actually getting weaned off from the ventilator, when the patient is actually at the end of the spontaneous breathing trial, whether an expert is there at the bedside to measure this. But these, when you study it, then you obviously measure it and find out that there is a benefit. But I personally think that BNP is something that can be easily done. And if you can repeat a BNP before and after weaning, that can help us to find out whether cardiac dysfunction is responsible for it or not. Now, if you find that heart failure is preventing weaning, what are the strategies that we usually take? If it is possible, you can offload the patient more with diuretics, or if the patient is on dialysis, then by more of hemofiltration or fluid removal. Second is you can try to reduce their blood pressure or decrease their afterload by nitrate infusions like GTN infusion. And you can even try to augment contrast by drugs, for example, milrinone, etc., or dobutamine. So basically trying to improve the cardiac functions while the patient is getting weaned off, and then take them off from the ventilator. So who are the patients who will prove to be difficult to wean? So these are patients who will be obviously having poor lung compliance like ARDS, poor chest wall compliance, increased resistive, that is asthmatic patients, poor central drive, those who are having neurological problems, neuromuscular weakness like GB syndrome, who obviously we know that these are patients like myasthenics and GB syndromes who have very prolonged weaning trials, very prolonged weaning. Patients who are having dynamic hyperinflation, remaining delirious, electrolyte imbalance, heart failure, renal failure, and diaphragm dysfunction. What is the role of ultrasound in weaning? There has been quite a few review articles on this. Now, to make a gist of it, ultrasound is useful, number one, to before you start weaning, you can look at the lungs to see if there's a lot of pulmonary pleural effusion, which obviously can be reduced or drained before you start weaning. Second is, once you start the patient on weaning, if you can count the number of B lines in each section, in each sector of the lungs. Again, I think this is pretty theoretical, but if you want, you can do it in various sectors of the lung. You can count the number of beelines. And once you have started weaning them after half an hour to 1 hour, you can again count the beelines. And if the beelines have significantly increased, then this patient is going into a weaning induced pulmonary edema. The other thing that can be picked up with ultrasound is diaphragmatic weakness or diaphragmatic excursion. So if somebody has got the easiest thing to pick up with an ultrasound is one-sided diaphragm palsy. That if you have a phrenic palsy on one side, then that's the easiest to pick up because the other side diaphragm is working fine. But if both the side of the diaphragm are not working well, then it's kind of difficult, and because there are absolute numbers are not very valid. However, if your diaphragm excursion is less than 10 centimeter, then that's kind of very suggestive that you are having significant diaphragmatic weakness. You can also look at diaphragm thickness of the diaphragm and the change in thickness of the diaphragm at the zone of apposition and all such things. Lastly, mechanical ventilation. There's a new definition which has where they say that mechanical ventilation can be divided into simple, difficult, and prolonged. Simple are those where the ventilator is discontinued after the first assessment. Difficult, ventilator discontinued from 2 to 7 days after the initial assessment. These are the majority of the patients about which we are concerned, because obviously when we talk about or when we try to learn about weaning, we are mainly concerned about difficult weaning. And there is a subgroup of patients who go into prolonged weaning. Prolonged weaning basically means when the ventilator cannot be discontinued beyond a week. Previously, it was said beyond 3 weeks, 21 days. But now I think the definition is changed to more than 7 days, or those who are requiring for more than 6 hours per day, every day they are requiring it. So these are prolonged weaning. And the most common causes are neuromuscular weakness, neurological patients, and those who are significant lung cripples. What about tracheostomy? When should we do a tracheostomy? Again, multiple trials, the largest being the TrackMan trial, which probably most of us know about. But if I have to just say one line about it, there is no evidence of doing early tracheostomy less than 4 days in medical patients. So most of the tracheostomy should be done at least after a week or at 10 days in medically for medical patients or medical cause of ventilation. If you have somebody whom you can predict that the neurological recovery will be very prolonged, then you can probably do a tracheostomy early. Or if you think that the airway problem will be permanent because of something which is obstructing in the upper airway, etc., then you can do a tracheostomy much earlier. But these are rare situations. In general, if for difficult or prolonged weaning, we need to wait for 7 days and give them a trial of extubation. If we cannot, then we do a tracheostomy and then continue the process of weaning. And lastly, many patients nowadays are even going into home ventilation, and home ventilation and weaning and taking care of them is becoming an important thing to study. And there are a group of physicians and a group of nurses who are now working on home ventilation and how best to keep such patients. So I've tried to put all these things in a nutshell. And if there are any questions, Dr. Bansal or anybody to answer. Not that I know it particularly. If I know, I'll be happy to answer.
Yeah. Thank you, Dr. Chakravarty, sir. Very nice and very simple, keeping it logical and simple. Please stop the share screen. Yeah. So while we wait for the questions, a few points from my side. Some of them you already said, some to recuperate and reiterate. First of all, we have this conundrum of whether we should give a half an hour trial or a 2 hour trial. Now, the pros for half an hour trial is that you extubate more patients because fatigue does not set in. And the con part of this is that more patients will require reintubation because you've not subjected them to a rigorous trial as you do when you give them a 2 hour trial. But when you give them a 2 hour trial, more patients are going to fail the trial. So we really do not know whether half an hour is better or 2 hour is better. So there are pros and cons for both half an hour or 2 hour. With half an hour, you'll extubate more, but you'll reintubate more. With the 2 hour, you'll extubate less, but then again the chances of ventilator-associated pneumonia and other complications will increase. So that is
how I personally deal with this is that if I think there's a pretty simple extubation, the patient looks pretty good, completely dependent on my experience, I just do them a half an hour to 40 minutes trial. If I think there's a bad COPD is on the ventilator for quite a long time, or somebody who looks like he's going to fail, I give them probably a slightly longer time. But there's definitely merit in keeping somebody on a spontaneous breathing trial for more than 2 hours.
Yes, absolutely. And if they fail at trial, they should be at rest for 24 hours because the diaphragm needs 24 hours to rest. So just taking that forward.
Absolutely.
Difficult patients. So there is another school of thought which says that actually you can give a 24-hour spontaneous breathing trial in certain patients which are prolonged mechanical ventilation or who have failed weaning or who are neuro patients or otherwise deemed difficult to extubate. You can give them a 24-hour trial in these particular subset of patients. There is a school of thought to that also and makes some sense. Then coming to neuro patients. So like you said, a GCS of 8 cannot be taken at its face value, but then there are no fixed criteria for neuro patients. When we have a weaning failure, most of the patients develop a higher respiratory rate and a low tidal volume. That is how they fail most of the times. But the commonest cause of weaning failure in the neuro patients is hypoventilation. They exhibit hypoventilation or they tend to retain secretions because secretion actually clearance depends on how good your brain is because the reflexes come from the brain for the oropharyngeal airways. So in general, for neuro patients, GCS should be more than 8. They should be able to follow simple commands like look at your eyes or maybe just grip your finger. Secretion should be less than 2 hourly. That is the definition of less secretions or secretions within control, not requiring suction more than 2 hourly. And good cough reflex and a gag reflex. Now, what is a good cough reflex? What is a good cough reflex is mentioned everywhere. Nobody knows. There is no clinical criteria to say what is a good cough reflex, but if you have to objectivize it, a NIF of around -25 is a good cough reflex. Okay, so just that thing. Now coming to causes of failure, like you very nicely showed wheans now. Just two simple things. Please remember the muscle weakness due to either nutritional deficiency, you have not fed him well. That is a very common thing in the ICU. 50%, the patients get only 50% of their calories. It has been seen in many studies. The patients are not fed well, especially in our ICUs. That leads to nutritional deficiency. Being on the ventilator leads to ventilator-induced diaphragmatic dysfunction and weakness and the other respiratory muscle weakness. So the primary cause is muscle weakness. Second being, like you said, cardiac dysfunction. And amongst cardiac dysfunction, it's all right if he has systolic dysfunction, you can probably be aware. But if he has diastolic dysfunction, it's difficult to pick up. One thing I would like to add to that is that when there would be diastolic failure during a weaning process, the cardiac output will go down. So another test you can do is look at saturation gap. You can do a venous ABG and then you can see the difference whether the saturation gap is widened. So that will indicate the cardiac output has fallen and you can actually make out that there is probably a cardiac dysfunction going on. Now coming to the thing about phosphate.
Regarding cardiac dysfunction, I just wanted to regarding cardiac dysfunction, I just wanted to make another point, which I did not mention in my slide, is that if you have a transpulmonary thermodilution, which is attached to it, then you can also measure the, the EVLW going up during weaning.
Yes, absolutely. But that is...
And there are some people who have studied hemoconcentration. So during weaning, they have shown a 5% increase in hemoconcentration because of shift of fluid to the pulmonary circulation, causing pulmonary edema. I'm not
No,
I'm not sure how
that I,
practical it is, because
yeah, yeah.
I've never used
That,
it.
that I think is a bit stretching it a bit too far, 5% hematocrit. But yes, extravascular lung water, B lines, BNP, but then BNP is costly. It does not become cost effective. BNP is a costly test. So B lines, if you're good at it, if the IC people are doing B lines, yes, or a venous saturation gap widening, that is also feasible. And then coming to failure of weaning, please look at hidden diseases. Sometimes patients do not give the history, or they do not know hypothyroidism, muscle diseases, and underlying early ILD, COPD, all these. And then coming to extubation. So the latest recommendation is that high-risk patients should be extubated to either NIV or high-flow nasal cannula. Either of them can be used. And what are high-risk patients? Those who are cardiac patients, those who are obese patients, ventilated for more than 7 days, or elderly. So preferably you should go on with high flow or NIV to these patients for the first 24 to 48 hours. And finally, about COPD. So sir very rightly said that you can use NIV freely in these patients, but at the same time there is a small subset who do not do well on your trial, on a weaning trial. They do fairly badly. So these patients cannot be extubated to NIV. We cannot blindly put the patient on NIV. If there is some scope, yes, borderline cases definitely, but there are patients who fare very badly, and these patients probably go on to prolonged ventilation with tracheostomy and all. So these patients, one has to be careful for the COPD patients. So those were the things I just wanted to add to the wonderful presentation sir has made. Very lucid, very simple. Anything else you want to add, Chandrashish sir?
No, I think the last thing that I want to say is that in spite of the fact that we learn so much and talk so much, at the end of the day, I think after almost a decade of doing this, I feel that weaning will always remain a mix of art and science, and we have to the experience of the physician will always play a role in difficult to wean patients.
Yeah. And so just one thing, one should be careful about weaning and extubation. Do not take it lightly, because reintubation has a mortality rate of something like 40%, I think. It has an extremely high mortality rate, reintubation, because you tend to put the patient into VAP, and other thing is it goes into respiratory distress, inflammatory cytokines, lung injury. I think the reintubation mortality rate is 40% or something. So one has to be very careful with this. It's not to be taken lightly, and it's a very important concept. And like sir said, the art and science of weaning. Maybe I should have kept it the art and science of weaning rather than the art of weaning. Both the things are there. So thank you, okay, sir. Thank you very much. See you again. Thank you so much.
Thank you very much. Thank you. It was a lovely session. Thank you.